Tonight, thank you to everyone in attendance to this lecture, and welcome to the first of our orthopedics series lectures. Tonight, I'll be speaking on the conservative management of low back pain. I have no disclosures. The objectives of the presentation today are to go over the epidemiology of low back pain in the general population, review relevant spinal anatomy, discuss common causes of low back pain. Then we'll go over key parts of a spine evaluation that one would expect in a clinic visit to help assessment, as well as determining factors for further workup and ordering advanced imaging. Then we'll discuss significant characteristics of lumbar disorders, including axial pain, as well as pain that radiates from the spine to the leg. And then we'll finish with a discussion of management of low back pain and then summarize what we discussed. Low back pain is a common health problem with an estimated 50 to 85% of adults experiencing at least one episode of back pain during their lifetime. Despite several peer-reviewed published studies on the prevalence or incidence of low back pain, there's still little consensus regarding its epidemiology and its risk factors, partly due to the different definitions groups use to study low back pain, the different etiologies of low back pain, and the different methods taken by these published studies. Here, I'll present findings from a recent 2019 study of patient-reported low back pain in North America and various European countries. And it's been estimated that up to 7% of the population will develop low back pain annually in these countries, and at any given time, up to 20% of the population has low back pain. However, other studies have reported incidence rates as high as 28% and prevalence as high as 82%. These values likely differ based on the different methodology and study populations used for data collection. The point prevalence in a different study of low back pain conducted and published in 2017 was estimated to be about 7.5% of the global population, or around 577 million people worldwide. Low back pain is the leading cause of disability worldwide, with a burden that has increased by over 50% from 1990 to 2015, primarily due to the overall decline in mortality and the increase in life expectancy with modern healthcare, resulting in an aging global population and expansion of non-fatal burden of loss of health and injury, which has amounted to an estimated 65 million years lived with disability globally by 2017. This is associated with increases in healthcare expenditure and insurance costs, missed days from work, and reduced work productivity. Back pain is one of the most common causes for patients to seek emergency care, and it is also the most common reason for workman's compensation and lost work hours and productivity. In 2016, a published study looking at among 154 conditions demonstrated that low back pain and neck pain had the highest amount of healthcare expenditure in the US, with an estimated $134.5 billion. This was followed second by musculoskeletal conditions other than spine pain, diabetes, and heart disease. So low back pain afflicts all ages, from adolescents to the elderly, with incidence known to increase with increasing age. Among risk factors, studies have reported that the odds of low back pain was higher in male patients than in females, with an odds ratio greater than 1, with a very wide range from 1.1 to 17.3. While for certain age groups, it was females that were more likely to report low back pain and present to a medical provider. Risk factors for developing spine pain are multidimensional. Race and genetics, intensity of physical activity, spinal load, activities that involve lifting, bending, or twisting, low socioeconomic status, including low education level, poor general medical health, including increased body mass index, a affected psychological state, especially with depressed mood, and occupational and environmental factors such as low job satisfaction, monotonous tasks at work, working with heavy weights, lengthy periods of standing or forward bending, all contribute to the risk of experiencing low back pain. But what constitutes low back pain? The global burden of disease studies have defined low back pain as pain in the area on the posterior aspect of the body, from the lower margin of the 12th ribs to the lower gluteal folds, with or without pain that refers into one or both of the legs, lasting for at least a day. Low back pain is frequently classified based on several clinical characteristics, among which is the duration of symptoms, where acute back pain is often defined as lasting less than 4 weeks, subacute lasts from 4 to 12 weeks, and chronic back pain lasts over 12 weeks. Many patients do not present for medical care for acute low back pain, as it typically resolves on its own without intervention. About 20% of those with acute back pain do go on to develop chronic back pain. However, even under these circumstances, it's reassuring that fewer than 1 in 3 people living with chronic back pain have associated substantial restriction of participating in work, social activities, and self-care for 6 months or more. Often in clinic, we're asked, what is causing my back pain? For about 85 to 95% of people, so a majority of people presenting to primary care providers with low back pain, they do not have a specific identifiable origin of their pain, and only a small proportion have a well understood systemic pathologic cause. The etiologies of back pain differ depending on the patient population, and for the most part, the majority of patients have mechanical or musculoskeletal back pain, meaning pain that arises intrinsically from the spine, intervertebral discs, or surrounding soft tissues, and which is often nonspecific, meaning it could be a combination of the above structures. And the proportion of people presenting to primary care with a serious pathologic cause of low back pain that's associated with what we consider red flag symptoms that requires more than conservative spinal care is low. And for certain conditions, it's estimated to be about 5% for inflammatory spondyloarthropathies, which means an underlying rheumatologic or inflammatory condition. It ranges up to about 4.5% for folks presenting with vertebral fractures due to low bone density. About less than 1% end up presenting and turning out to have a cancer that underlies their back pain. 0.04% end up with cauda-equina syndrome, which is compression of the nerve roots as they originate at the bottom end of the spinal cord. And even less than that present with infections that underlie their spine pain. So as an example, on the right half of the screen, this lumbar x-ray is from a patient of mine who presented with chronic ongoing right low back pain that inhibited this patient from working and studying and concentrating, but whose x-ray images were completely normal. And the radiologist read this as normal. And we continue with the management of ongoing back pain for this type of non-specific or musculoskeletal type of back pain. So here we'll review the spinal anatomy, and there's physiologic curvature at all parts of the spine. Namely, we separate the spine into 3 distinct portions, cervical being the upper part at the neck, thoracic being where the lungs occur, and lumbar, which is the lower back. There's a physiologic curve at each of these levels, a natural lordosis, which means a curvature backwards along the 7 cervical vertebrae, a curvature forwards called kyphosis at the 12 thoracic vertebrae, and again, lordosis at the lower 5 lumbar vertebrae before reaching the tailbone called the sacrum or coccyx. The spinal column is designed to protect the spinal cord towards the upper portion, roughly from the mid-back to the lower, from the neck all through the mid-back down to the lower part of the back. Here are the relevant bony anatomy parts of a vertebral body. Without going to specific detail about each of the bony parts of this anatomy, I'll just point out the relevant portions that might refer to the clinical aspects of our talk here. I'll point out here that between each of the vertebral bones, there are processes of the bone allowing it to interface at another part behind the disc alongside of the spinal cord with another bony part coming from the vertebral body, either above it or below it. And these are facet processes. These are joints in the spine. You'll note that here where the cursor is the intervertebral disc, which we'll be talking about further in this discussion. And along the center part of the column, the bones form a tunnel where the spinal cord and the spinal nerve roots travel from head to toe, which we refer to as the central canal. And at each particular level, adjacent to the level of the disc, we'll have yet another opening or channel where the spinal nerve roots of each level exit out of the central canal. This will be called the neural foramen. Between the vertebral bodies, the load-bearing intervertebral discs also are supported by ligaments, and together with the bony structures, all of these elements house and protect the spinal cord and nerves. And then exterior to the spinal column that we just showed, supporting the spinal column are muscles of what is referred to as the core, which serves to protect and then stabilize that spinal column, and also allow one to produce dynamic motion. Core muscles, when weakened or atrophied, often associate with greater low back pain or the onset of low back pain. And these are actually key muscles targeted for conditioning and strengthening and stretching through physical therapy. So one might hear a lot of therapies referring to the core. And these muscles include the erector spinae in the back, quadratus lumborum along the sides of the spine on either side, a psoas muscle that runs on either side towards the front that also activates with bending the hip or bringing the hip up. And then in the abdomen or abdominal wall, you'll find several layers of muscle, which will referred to as transversus abdominis, external obliques, internal obliques, rectus abdominis in the front, which folks know as the abs. And then the core also includes the buttock muscles or the gluteus muscles, as well as particular muscles along the side of the ribs, the latissimus dorsi. So here's a table showing in broad categories the common causes of low back pain that you might commonly consider, broken down by age group. Starting with pre-adolescent population are developmental issues such as scoliosis, infection, tumor, or trauma. In the adolescent or teenage population, common causes of low back pain include trauma such as spondylolysis, which is a fracture of a portion of the spinal element near those joints in the posterior part of the spine that results in commonly associated alignment issues, as well as spinal development issues that affect the curve of the spine, such as having a low back spine with the arch that is too great. Adolescents can also have disc pain, and it'd be important for this group of patients to make sure that we don't miss any of the inflammatory or rheumatologic issues. Leading causes of low back pain in the adult population are commonly related to the disc, mechanical or non-specific pain yet again, and arthritis. And in the elderly, frequently disc herniation, arthritis, spinal stenosis, which we'll be discussing a little later in the talk, and other more concerning red flag conditions that we mentioned previously. So here we'll go through key parts of an evaluation that one might find if they present to a spine clinic. And so a lot of time will be spent on taking the history, describing how the back pain occurred, what was the mechanism of injury, was there a lifting injury, was there a trauma, was there a motor vehicle accident, might there be a history of low back pain already preceding this. But oftentimes, if there is a degenerative process with folks who are a little older in age and undergoing arthritic conditions, they might incur impingement or contact of one of their nerve roots due to restriction of space where they exit without having any trauma or preceding event. And that just might occur due to just the passage of time. We'll make note of other medical history, making sure to not miss red flags. Also making note of surgical history, especially prior spine surgeries or hip surgeries, and then document their occupational history for the patient, taking note of any work-related demands, any demands requiring lifting or prolonged sitting at a desk that might be one of those risk factors we discussed about precipitating low back pain. We'll also ask about what is the quality of the pain. And this description is actually fairly important for us to help determine the nature of where that pain might be coming from. That will be one of the earliest clues. And we categorize the quality possibly into two possible sources. Either it's related to a nerve that's being irritated, which we'll refer to as neurogenic, and some folks refer to as neuropathic. The quality of that type of pain often is described by folks as burning, electric, shooting, or buzzing. Of note, if it's related to nerve root compression caused by an acute disc herniation, the pain might change over time, initially presenting with low back pain, followed by pain going down the leg. And then if it's more of a degenerative condition where the canal, the tunnel where the spinal cord travels from head to toe becomes restricted, that might also present with not only back pain, but stiffness and a lower extremity pain in both legs. The other type of pain that we categorize pain would be nociceptive, which is the general pain other than or different than nerve pain. And that could be described as achy, deep, throbby, sharp, stabby even, stiffness. And we think about possibly that coming from joints such as arthritis, which commonly affects right down the middle of the spine, and also accompanied by stiffness. So the description of the pain folks provide in clinic is fairly important to help us determine what's the cause. The other part that is important to help us determine where pain or what are the structures causing pain is coming from is where if the pain in relationship to the spine. So is it strictly in the spine, which we refer to as axial spine? And that could be related to disc pain or facet joints or even muscular and connective tissue pain. Or does the pain travel from the spine and go elsewhere to other parts of the body, commonly the buttock or to the flanks, in which case we'll think about joint pain or sacral pain, or even think about other parts of the body that's not related to the spine, such as the hips. And a subtle difference between referred pain, which is pain that you feel in a different part of your body other than the spine, is radiating pain, which is commonly associated with nerve pain. And that's the type of pain that travels further down the leg than referred pain typically would. And so in those cases, we think about spinal nerve roots, maybe the nerve roots after they exit the spine that occur in the buttock or the hip area, or peripheral nerves further away from the spine as they travel through the leg that might be causing this type of radiating pain. We always can't forget that it's not just about the spine. Sometimes it's about circulation that causes pain in the leg. And so we'll always have to keep our radar fairly open to looking for other issues that might be causing leg pain. Other characteristics that one might be asked during clinic is what worsens the pain? What are the postures and the activities that make your pain feel worse? For example, if it's bending forward and it causes worse pain through sitting, that increases pressure on the discs. Increased pressure can also come from coughing, and we often think about activities such as those as aggravating disc pain. However, if the pain is aggravated by arching backwards or twisting, we'll commonly think about a central stenosis. And that might not necessarily be an active extending backwards, but a passive extension of the back as one would walk down a hill, for example, that requires the person to lean backwards. We'll often, include cervical, sort of the neck range of motion, as part of this sort of a description of pain. And if pain is brought on even down in the legs, we'll have to keep our, again, radar open to the possibility that some pain is coming from the neck. Particular activities that might aggravate joints such as the sacrum specifically might be sitting or standing up from a sitting position. And that makes us consider the spine at the lowest part, which is the sacral part that interfaces with the pelvic bone. It's important to factor in the patient's mood. If they have an underlying mood issue that they're seeing psychology or psychiatry for, such as depression or anxiety or past history of trauma, as we mentioned this as a risk factor earlier on in this talk, that actually might amplify their experience of pain. If sleep is poor, pain might be experienced at a greater intensity as well. We'll look for associated factors in the extremities if they're affected. So if they're having leg pain, we also want to know there's swelling there, skin changes, sensitivity, touch, temperature or color changes, to rule out other more complex nerve-related pain. And then the red flags. Red flags are key to make sure that we don't miss more severe or serious conditions. And red flags also indicate we might have to involve other types of providers and think about if we need to involve surgeons as well. So these include focal weakness, leg buckling, or legs, giving out during walking, or sensation of leg heaviness or fatigue. Discoordination could be a more subtle form of weakness. One might notice tripping instead of just the leg giving out. They may experience falls for uncertain reasons and not making that connection that it's related to the spine. Other condition or other symptoms of neurological deficit are sensory loss. So folks might feel that one part of their leg just doesn't feel certain things that touch it, as well as the other part of the leg. There may be loss of control of bowel or bladder function, pain or numbness in the groin area. We will also take note of if their patient has a history of cancer, that raises our suspicion to look for the possibility that cancer has spread. They might experience constitutional symptoms such as fever, chills, sweats, unexplained weight loss, or pain occurring only at night without those aggravating maneuvers or postures that we mentioned earlier. We want to know if there's recent surgery or a recent injection that might be associated with a source of infection. And then we always ask about if there's a history of trauma, such as a motor vehicle accident. To help us come up with a better plan or a management of low back pain, we'll often review medications, what's been tried in the past, what folks are taking currently, what's worked, what are the side effects that folks have experienced that don't make particular medications good choices to repeat. If folks have done prior interventions or injections, how much physical therapy they have tried, exploration of complementary or alternative medicines. I won't go through too much of the physical exam, but it includes a combination of palpation of parts of the spine that might cause pain to identify focal areas. We'll go through a neurological exam testing for strength, sensation, and reflexes that might help us identify where along the spine symptoms might be coming from. And then we'll apply certain maneuvers to test out the nerves, namely that we might cause certain tension or irritation of the nerves that commonly end up reproducing the patient's leg pain to help rule in or rule out that the nerve is involved. So moving on to lumbar disorders, we'll be starting with axial lumbar pain, which is pain that occurs along the spine, down the midline, maybe off to either side of that midline, but doesn't really travel that far as out to the thighs or down the legs. So this is called axial lumbar pain. Disc pain can be one source of pain that really occurs right at the midline or along the sides of the spine. It can be associated with any strain or injury to the disc, including the occurrence of a disc bulge or herniation, as well as the process over time of disc degeneration. Pain can be felt as deep and sharp and refer sometimes to the sides of the spine or to the flanks or even to the hips. Pain is aggravated by flexion, like bending forward in a seated position or even lifting. Another source of pain can come from those joints, the interface between two vertebral bodies behind the spinal cord, called the facets, and this is facetogenic pain. It's commonly a arthritis of the facet joint or a stress across the joint. It accounts for between 5 to 15% of cases of chronic axial low back pain. Facet joint pain may be due to not only increased compressive stress, as one might imagine with other large joints, such as the knee or the hip, but also facet joint capsular stretch and distension. Most commonly, facetogenic pain is the result of repeated stress or low-level trauma that accumulates over a lifetime, leading to inflammation and stretching of that joint capsule as possibly the shape of the joint changes. And there's insidious onset. Predisposing factors include a malalignment of the spinal column called spondylolisthesis or degenerative disc disease. And we'll be describing that in a few more minutes. Trauma, such as a motor vehicle accident with rapid deceleration, especially if there's a seatbelt that restricts parts of the low spine, may cause lumbar facetogenic pain, most involving the lowest level at L5-S1. And the mechanism of injury of these cases is often a combination of flexing too far forwards or bending too far forward, stretching the spine, and rotation of the spine. The most frequent complaint of facet pain is right down the spine. However, facet pain can also refer or be felt to refer to the flank, the hip, and the thigh. Studies in the past have demonstrated that facet joint pain, when tested under research settings in healthy volunteers, either by injecting into the joint of the facet joint or stimulating the sensory nerves of that facet joint, that pain can refer to these general patterns in the legs, to the groin, the hips, lateral thighs, most especially for the upper lumbar joints, and to the lateral and posterior thigh, which is the side and the back side of the thigh for the lower lumbar joints. Abdominal and pelvic pain even have been described. Infrequently, the lowest two levels of the lumbar spine with facet pain may actually reach the lower leg and the foot that mimics sciatic pain. Facet pain on exam, when we see patients, may actually present also with tenderness when we palpate the spine along the sides of the spine. Pain can also be reproduced with having folks extend and rotate backwards, tilting to the side, or even brought on by flexing forward very deeply. So associated with facet joint pain and irritation of those joints may be a reactive process. Often we find that folks that have facet pain might have muscular pain, which is a reflex or a spasm of that muscular core area that protects the spine. These often involve muscles called the multifidus along the sides of the spine on either side, the left or the right, as well as the quadratus lumborum muscle that we refer to that are a little further away from the sides of the spine on either side. The hallmark of myofascial pain is the presence of palpable knots, which we refer to trigger points. It's a taut muscular band that runs along the direction of the muscle itself. It can often refer pain in a defined pattern spontaneously, or after one pushes on that muscular knot and the person feels pain not only under where it's pushed, but also into referred patterns away from that knot. So for example, in this image, if the knots occur in this quadratus lumborum muscle where the X's are, sometimes they have characteristic referral patterns to the buttock. Moving on from axial lumbar pain is radicular pain, which means the pain that travels and radiates down the leg. Radicular pain often indicates irritation or impingement of spinal nerve roots, presents with not only back pain, but also pain going down the leg, and it frequently affects the lower extremity in a distribution that maps to known patterns associated with a nerve root, as shown in this schematic on the right. There have been regular distinct patterns that we use to identify which nerve is involved based on where the pain occurs in the leg. However, many people will also have multiple nerve root involvement with their radicular or sciatic pain, and there's considerable overlap of the distribution of patterns of these nerves. For example, if it was a very clear radicular pain affecting the L5 nerve root, pain will commonly affect the outer side of the leg and may reach all the way down to the big toe. Usually, the more irritated the nerve, the further down the leg the pain radiates. Symptoms may be acute, often associated or preceded by a lifting injury or a bending or twisting activity, or have gradual onset over time. Leg pain may be greater than the actual back pain. There may be associated numbness and tingling in the buttock or along the affected part of the leg where there's pain. One might feel or experience focal weakness that matches that particular affected nerve root. So for example, if it was the L5 nerve root, there may be focal weakness of flexing that big toe upwards. Pain may be aggravated by coughing, sneezing, straining, sitting, or bending forward. Especially in the younger patient, typically in the 20s to 40s, this radicular pain is typically due to a disc herniation. If local inflammation occurs or a disc material affects the local nerve roots, this might then lead to that leg pain. However, the majority of cases of radicular pain caused by a disc herniation are self-limiting. They can heal spontaneously with symptoms resolving without surgery. The clinical course of radicular pain or radiculopathy varies, as well as the effectiveness of conservative management. So in some patients, the symptoms decline after a week or two, but in other patients, pain may continue for several months to years. However, there can be spontaneous resolution, which is the good news of disc herniations, and clinical improvement correlates with and a lot of the times precedes the resolution of the disc herniation itself that one might notice on a repeat MRI, for example. So although each person's case is unique, sometimes pain lasting for years, the favorable prognosis overall of acute disc herniations and radicular pain supports our general approach for conservative management, at least for the initial weeks to months for patients presenting with such pain. There are various degrees of herniation characterized by the dimensions of the herniation and whether or not fragmentation of the disc material occurs into the space. A 2020 study examining whether the size of a disc herniation is predictive of the failure of conservative management and the need for surgical intervention within 2 years after an MRI. It showed that the percentage of the spinal canal occupied by a disc herniation had no predictive value of which patients would fail non-operative treatment and which would require surgery. They found that patients who did not receive surgery had an average herniation size that occupied 31.2% of the canal, while patients who ended up having surgery also had an average herniation size that occupied 31.5%. So not much of a big difference of the percent occupied by that disc between the two groups. In older populations, narrowing of the space around the nerve root, as we mentioned, related to what we call the neural foramen, where this nerve exits out of the spinal column, can occur due to not a herniated disc, but due to degeneration of the disc and degenerative changes that are actually associated with flattening of the disc, among other changes. So distinct from the mechanism of disc herniation, we refer to this as degenerative disc disease or disease. It's not necessarily to be considered a disease, but just the fact of aging over time, and which can be precipitated by an earlier disc herniation, but relates to the drying out of the internal structures of the disc, leading to a loss of elasticity or cushioning that the disc provides in the spine, and eventual flattening or collapse of the disc, as you see in this pictorial, that higher up, you'll see the normal disc, and as over time, there may be disc degeneration, bulging, a herniation, the disc thins out, it dries out, the internal material loses some hydration. As discs flatten, a lot of the biomechanical and body weight stresses get passed on to the vertebral bones, as well as the joints in the spine, leading to arthritis and spur formation. This degenerative change can be prominent at the lowest level, L5-S1 here, where you see a flatter disc. On MRI, usually dried or desiccated discs usually have a darker appearance, and healthier discs usually have a brighter or grayer appearance. And so in this particular patient, the MRI shows that the lowest level, L5-S1, as well as L4-5, have experienced some desiccation already, with the L5-S1 flattening more. So with degenerative disc disease, deterioration of the disc in the spine, biomechanical loads, as we mentioned, can transfer to those facets. Those facets can experience arthritis. They can also experience enlargement, which we'll find has a significance for the next lumbar radicular pain disorder. And even some of the ligaments in the posterior parts of the spine can thicken with the aging process and contribute to that particular process. And these can all be associated with axial back pain, but they can also lead to narrowing of the spine spaces where the nerves exit. So we refer to this as the neural foramen, as well as that central canal where we showed that the spinal cord travels down from head to toe. So with central spinal stenosis, there can be more than one level of pain radiating down the legs, and not just one particular nerve, but more than one nerve being affected. And in this condition, one might experience sensations of heaviness or fatigue in the leg, often provoked by being upright in a standing or walking activity, and improve soon after bending forward or sitting down. I do want to note here on the diagram on the right-hand side, it shows that on the left column, the progression of neural foraminal stenosis, which is a side view of the spine where the nerve roots exit out of the spine. You'll see up here that the space here is normal, a normal looking space where the nerve root is, which is the dark dot in the center of that space. And as the space narrow or experiences this stenosis, often related to a disc bulge, that the space progressively tightens around the nerve. At which point, at any point along this progression, one might experience focal pain going down the leg. On the right column is the progression of central stenosis, where we're looking in a cross-section of the spine, looking from head to toe. Centrally, I think where all the nerve roots run, at the top is fairly open. As the central stenosis progresses, disc material can push back. The facet joints who experience arthritis can enlarge. The ligaments that we mentioned here can also thicken, which is this dark portion right here. And so all of which leading to what previously was a circular space that tightens down to a very small triangular space, which is what we refer to as central stenosis. And all the nerve roots that travel through this tight space can be affected, leading to this sensation of heaviness down the leg. So what about management? And so we'll start with diagnostics. These include X-ray images, MRI images, CT scans, electrodiagnostic studies. Given the common positive natural history of acute low back pain, as we mentioned, our medical societies agree that imaging right away is not recommended for most patients with nonspecific mechanical low back pain, especially in the absence of those red flags that we discussed. The American College of Radiology appropriateness criteria for low back pain recommends imaging only if there is no improvement after 6 weeks of conservative medical and physical therapies, or there's a high suspicion for malignancy, fracture, infection, or stenosis. Folks might present with radicular pain, but even the presence of pain going down the leg with low back pain is not an indication for early imaging. Early imaging with even an X-ray can often be associated with worse outcomes as it is likely to identify even those small minor abnormalities that otherwise are not clinically relevant to the patient's presenting pain. And so it might just end up finding things that show up on the image that otherwise was not affecting the patient. A randomized controlled trial showed that the early routine use of MRI imaging, if it's used too early or too often, can end up increasing the occurrence or prevalence of patients going for spinal surgeries unnecessarily. So it's agreed upon that it's appropriate to begin therapy without imaging in adults, especially younger than 50 years, and in those older than 50 years, if there's no concern for a systemic disease. Lumbar X-ray is often used if we end up moving on towards imaging. It's used to evaluate for spinal alignment, so we want to know if there's any spondylolisthesis. We often use X-ray to see the curvature in more than one direction to see if there's any scoliosis. We use it to evaluate bony structures for fractures. And in particular series or a particular protocol, we'll use X-rays with patients bending forward and bending backwards to look for stability of the spine. Lumbar MRI or CT is considered advanced imaging. And so it's often used when we're looking at not just axial lumbar pain, but pain that radiates down the legs. MRI is used very effectively to evaluate for soft tissue abnormalities, including the disc, nerve roots. It can also find other red flag abnormalities such as tumors. And it allows some evaluation of how active inflammation might be. For example, in the facet joints, we'll often see some fluid and brightness of that fluid in affected joints. CT scans are often used to evaluate the bony parts of the spine. They look for bone spurs. It often helps surgeons who are planning procedures. It can identify calcifications of a disc, and it's often employed when MRI is contraindicated, especially, for example, in patients who might have metal clips in vasculature or metal implants such as cardiac pacemakers that prevent patients from undergoing an MRI, which uses a very strong magnet that can affect metal. For nerve conduction studies, we employ these studies to evaluate for neural or nerve-related abnormalities. We can use these to confirm the existence of nerve root dysfunction, to also exclude other types of peripheral nerve problems. Often we'll be able to identify with more specificity than on an imaging study which might show multiple different findings without actually telling us which nerve root is actually underlying the source of the pain. So we'll use these electrodiagnostic studies to look at whether the issue at the spine of the nerve itself is coming from the spine or outside of the spine. We can use this to identify how long the process that is found has been going on, if it's an active process or if it's a process that has occurred and now there's neural recovery. And so we often use this when the diagnosis is not very clearly coming from the spine. Patients might have lower extremity pain, weakness, sensory changes, MRI findings that don't really point to a spinal cause. Of note, it's important to understand that even if the nerve conduction study does not show a finding of a nerve being affected, it doesn't exclude that the nerve is actually affected or getting irritated. It just may not be severe enough to result in an altered electric signal picked up by the imaging or the diagnostic study. For management, we often employ these main areas, including physical therapies, medications, and interventions. So we'll start with physical therapies. In my field of physical medicine and rehabilitation, which has the goal of addressing disability, restoring function, and improving quality of life, part of restoring function means to help with alleviating pain. With pain being multifaceted, having biologic, psychological, and social influences, as we discussed about risk factors, we often take a multimodal approach to the conservative management of low back pain. And so this approach or framework of understanding and conceptualizing pain also underlies what I'll mention here is the detailed approach that a UCSF, a huge research effort within our department, is taking called UCSF REACH. And it seeks to study the different types of low back pain, the mechanism of how they occur, in order to understand what are the predictors of low back pain and possibly the predictors that might influence the effectiveness of therapies that we try to address low back pain, with the goal being that we might design and formulate very much more specific approaches to addressing particular mechanisms of low back pain. So with this multimodal approach, I often use this in my treatment plans, as well as ways to discuss and provide education to patients about to help them understand their pain and help them understand the management of low back pain. To discuss the management that we employ for low back pain, I'd like to kind of switch gears and use our society guidelines. So namely the 2020 guidelines from North American Spine Society for the diagnosis and treatment of low back pain, to kind of in a question and answer fashion, go through common questions that patients might have and provide the recommendations from our society backed by the evidence that exists to support this approach for managing low back pain. So often in our areas, we use evidence that comes from research, either clinical studies or reports of patient cases, to help us get a better understanding of what occurs out there, as well as a better understanding of what one might do to address similar situations that come up. There are different grades of the evidence that then can be interpreted as a strength of the recommendation. So just to orientate you on the next few slides, the strength of the recommendation will come in categories labeled as A, B, C, or I. A being it is recommended, whatever the recommendation might be. B is the strength of the evidence is fair, so the recommendation is just a suggestion. It could be labeled as C, given that the evidence supporting the recommendation is poor quality evidence, and so the recommendation can maybe just be considered, or it could be labeled as I, indicating that there's just not sufficient evidence, or the evidence that exists is conflicting, so the society can't actually either support or refute that recommendation. So I think maybe the first example might give you just an idea of how this might go. So the question would be, if patients undergoing treatment for low back pain, what are the outcomes, including duration of pain, intensity of pain, functional outcomes, and return to work status, if one were to employ bed rest versus active exercise? That is a common question that comes up. And so it could be considered, this recommendation suggested that patients with acute low back pain, those that exercise more at baseline and use exercise to facilitate recovery, are predicted to have better functional outcomes over time compared to patients who do not exercise or only use bed rest to help with recovery. So it suggested from this, for example, that exercise is better than bed rest. Other questions are, how effective is bracing for low back pain? The evidence is insufficient or conflicting evidence that bracing results in improvements in pain and function in patients with subacute low back pain. How effective is self-directed exercise? There's actually pretty good evidence. So the recommendation is that back school is recommended to provide improvements in pain and function when compared with general medical care, modality care, or a simple handout. And outcomes have been followed up to 6 to 12 months for chronic low back pain. And back schools are educational and training programs where lessons are given to patients by a therapist. How effective is the McKenzie method? So the McKenzie method is a physical therapy approach developed in the late 1950s by a New Zealand physical therapist, Robin McKenzie, to diagnose and treat musculoskeletal conditions based on their clinical presentation and movement patterns and postures. The McKenzie method is an option for the treatment of chronic low back pain. So with labeled as C, that is a suggestion. In the literature itself, the McKenzie method has been shown to have moderate evidence for acute low back pain, but it has been shown to make moderate to no difference for chronic low back pain. How effective are heat or cold? So the evidence suggests that the use of heat for acute low back pain results in short-term improvements in pain. And what about traction? So in patients with subacute or chronic low back pain, traction is actually not recommended to provide clinically significant improvements in pain or function. So I typically discuss with patients to, if they want to pursue traction, to proceed cautiously, probably under the supervision of their physical therapist before really employing traction on a regular basis. What is the appropriate timing, frequency, and duration of treatment with physical therapies? So there really have been no studies adequately addressing this question. Often we'll rely on physical therapists who see our patients to determine the progress that the patient is making with their exercises. Often it can end up being shorter than anticipated or longer than anticipated. Often we'll decide to schedule a follow-up exam probably about 6 to 8 weeks after their visit, just to see how their progress is. But there's not a very strong recommendation to really specify that physical therapy needs to be exactly, for example, 2 months. So what are some physical therapy exercises? They commonly focus on strengthening and stabilizing the core muscles, the extensor muscles in the back. Those are the ones we discussed at the earlier part of this lecture. Also the buttocks and hamstrings, all to help protect the spine. PT should also balance the strengthening of these core muscles with flexibility So especially to relieve excessive tightness in the hamstrings, buttocks, tendons along the sides of the thigh and the hips. So in addition to physical therapies, we have different approaches or physical modalities, and this is actually a complementary therapy. People often ask about how effective is acupuncture. So in patients with chronic low back pain, the addition of acupuncture to usual care is recommended for short-term improvement in pain and function compared to usual care alone. So there is actually some good evidence that acupuncture can be added to, for example, physical therapy or medications as part of a varied approach to address low back pain. How about spinal manipulation? So spinal manipulation is a technique where practitioners use their hand or device to apply controlled thrust to a joint respond to move it more than that joint would move on its own to hopefully relieve some of the stress. It's often performed by chiropractors, osteopathic physicians, or physical therapists as well. So for patients with acute or chronic low back pain, spinal manipulation is an option to consider to improve pain and function. Of note, osteopathic manipulation has also been shown to be effective in reducing acute and chronic mechanical low back pain. This would be pursued with osteopathic physicians. And yoga. So it's suggested that for mild chronic low back pain, yoga may offer medium-term improvements in pain and function compared to usual care, although improvements are not clinically meaningful due to low baseline pain. So we often will say that yoga is an alternative, for example, to physical therapy. It is a mind-body exercise. It often employs similar postures or stretches and strengthening moves employed by physical therapy, and can be explored. And aerobic exercise. So aerobic exercise is recommended to improve pain, disability, mental health in patients with non-specific low back pain in the short term. So we'll often try to provide the perspective during patient education to keep moving. Don't try to avoid pain by bed rest, but really try to keep moving. But try not to push through the pain, or try not to push beyond back pain. So aerobic exercise might help loosen things up, might help improve flexibility. It can often elevate mood, help with sleep. But the literature, it looks like, it shows that there's insufficient evidence for long-term benefit. We'll often have a discussion about how aerobic exercise might help, but really a lot of the targeted therapy should come from a physical therapy that works on strengthening those core muscles to help support the spine. So moving on to medications. What can we use for medications to help with pain? So non-selective anti-inflammatory medications such as ibuprofen or Aleve are suggested for the treatment of low back pain. So NSAIDs are effective for short-term relief of chronic back pain without radiculopathy or radicular pain. But studies have shown no difference between NSAIDs and a placebo for radicular symptoms down the leg. So it may help more with the back pain from a disc, but less helpful for pain actually occurring in the leg. We often weigh the risks of starting anti-inflammatories, given an increased risk in the elderly for gastrointestinal, kidney, or bleeding risks. Studies have also shown that Tylenol or acetaminophen has not provided better benefit or superior benefit than placebo. And just to mention that muscle relaxants have also been found in the literature to provide more effective pain relief in acute pain than in chronic non-specific low back pain. So as we mentioned, if patients come in with facet joint pain tied with muscle spasms, we'll often employ muscle relaxants in combination with an anti-inflammatory medication such as ibuprofen or Aleve. So the next set is medications that we use to address nerve pain. So anticonvulsants are a class of medications we use, even though they're anticonvulsants, we use those for nerve related pain in certain circumstances. But the evidence is that there's insufficient evidence to make recommendation for or against the use of anticonvulsants for treatment of low back pain. Similarly, for antidepressants, we'll use these. Things like nortriptyline or antidepressants such as Cymbalta, also for nerve pain. And there's pretty good evidence that antidepressants are not recommended for treatment of low back pain. There is the exception of Cymbalta, especially if the patient has mood disorders such as depression, that might actually help with the mood and the experience of pain. And then what about oral steroids? A lot of folks ask about oral steroids. So it's suggested that the use of oral or IV steroids is not necessarily effective for the treatment for low back pain. So again, I think the perspective from the message from the literature is that this is what has been presented and published from research. However, I'll have a lot of patients who will anecdotally say that they took the oral steroid and either they had really significant pain relief. Often we'll find that their significant pain relief only lasts while they're taking the steroid. But there are some folks that will say that they take the steroid and it got rid of all their pain, even after finishing the course of oral steroids. And then in terms of short-term opioids, it's suggested that the use of opioid pain medication should be cautiously limited and restricted to short durations for the treatment of low back pain, especially given their increased risk of misuse, abuse, and diversion. And then lastly, interventions is one of the other directions of our management of low back pain. To relay the findings from our North American Spine Society, for all of the interventions, there was insufficient or conflicting evidence. So all of the following interventions were given the label of I, and it means to suggest that the evidence is there. People have tried to study it, but there's been a lot of mixed findings. And some studies will say that these interventions that I'll present are really, really effective. Other studies say that there was no real benefit compared to placebo. It doesn't necessarily make us steer away from interventions, for example, because from our patients, we have commonly found that these interventions do end up helping on a case-by-case basis. And even in a general basis, but it's just that the evidence and possibly the way the studies have been designed do not have enough power to demonstrate a very strong, significant finding. And therefore, the following, I'll just present the actual literature versus the society recommendation. So for example, dry needling is something that we use for muscular pain or myofascial pain. Those trigger points that we talked about. A 2018 meta-analysis of randomized controlled trials that review the effectiveness of dry needling for these myofascial trigger points associated with low back pain found moderate evidence showing that dry needling in combination with other therapies could be recommended to relieve low back pain. However, the superiority of dry needling to improve function, such as walking, moving, tolerance of daily activities, remains unclear. An intervention that we use for targeting facet joint pain that we mentioned are facet injections of steroid. Here in 2015, systemic review looking over a lot of historical literature that exists, comparing among many studies. Looking at the effectiveness of facet joint interventions to provide greater than 6 months relief of chronic spinal pain, found only level 3 evidence that it would help facet joint pain. So level 3 means that The literature that exists consists of mostly observations and reports of individual cases versus a very strongly designed controlled study. And what about epidural steroid injections? And that is one of the most common injections that we provide to address spinal pain, as well as pain radiating down the leg, radicular pain, or sciatica. A 2012 systemic review looking over studies from over 1966 to 2011 for the effectiveness of these two different types of approaches for epidurals found that for lumbar radicular pain going down the leg, there was good evidence that the epidural steroid injections are effective. But for lumbar radicular pain due to that central stenosis that we mentioned, there was only fair evidence. So I'm not diving too deeply into the literature for these procedures because there's just a lot of different reports describing variable outcomes. And so this is just to give you a sense of how the studies look and typically what we might help patients understand as part of their management through a discussion that we might have in clinic. So in summary, low back pain is very common. It can improve or resolve with proper care and treatment. There are various causes of mechanical back pain. Early imaging for non-specific low back pain is not recommended in favor of physical therapies to help with recovery of low back pain. So thank you very much for your attention, and I'll be happy to take any questions.
Hi, Peter. Thank you for that great talk. I learned so much just listening to him. As you can tell by my intro, he's probably the at least most decorated member of our department as far as degrees go. So I always enjoy hearing Peter's discussion. I'm going to go through the Q&A. There's a question from the audience. What is the meaning of bracing as used on the slide about physical therapy management?
Yeah, so bracing, that's a great question. Bracing is really the use of a low back brace. So that's, I think the term might have been a little confusing, but that really just means wearing a back brace. And that could be a soft back brace with elastic band or Velcro, all the way to like a hard brace.
Okay, great. And this is a message. Here's another question. We've got lots of good questions, so thank you everyone for participating. How do the medical societies currently approach chiropractic professionals? Are they considered complementary or alternative providers? And to the extent that they become more complementary, any examples that illustrate?
Well, I think I would say it probably befalls the definition of complementary and alternative medicines. At least from my perspective, I don't necessarily have the answer from the medical society, but I often end up considering chiropractic therapy as part of physical therapy. And then the alternative and complementary therapies, I generally conceptualize as those coming with a sort of a different medical philosophy that hasn't really, gained ready traction within Western medicine. So I more consider chiropractic therapy as physical therapies.
Great, thank you. Here's another question. Can discs be repaired or replaced? And I imagine the insertion of an inflatable tube-like structure.
Yeah, that's a great question. I think more recently, we've seen sort of the evolution and the introduction that there are disc replacement procedures. It's a surgical procedure. So it does involve disruption of those tissues as part of a surgery. But there are certain specific criteria that the surgeons employ that qualify a patient as a candidate for disc replacement. Often they would like to see that there's not a strong degenerative process going on in other parts of the spine of the affected area, such as arthritis. They use disc replacements to kind of recreate the same height that the original discs might have had. But I think there's very specific surgical criteria that qualifies a patient for candidacy for that. Other than that, I think we'll end up either addressing a herniation, for example. Usually they undergo a procedure to remove some of the disc material that might be impinging the nerves. So often the discs end up being a longer term issue, and replacement may not be the most practical or easiest solution.
Okay, and another question from the audience. Do products like Icy Hot or CBD ointment offer any healing properties?
Yeah, I couldn't say I know about healing properties, but they do probably help with the pain experience. So Icy Hot and things like patches, lidocaine, analgesic gels and balms or patches can help provide soothing, like a soothing sensation. CBD may have other cognitive effects that I think the field is probably still trying to characterize and study to see whether or not there are other indirect effects that are not accounted for. But I think a lot of the measures that we employ and then we have available are more for management of symptoms.
Okay, and then is there a grade or recommendation on using cold for low back pain?
The study here, I think from the society guidelines didn't really identify that as a particular part of the evidence. The question that they addressed with the evidence was whether it was a heat or cold, so meaning like a temperature modality. So which one of them was better rather than isolating if it was cold alone. But generally, I'll advise that heat is something very common that I'll advise patients presenting with low back pain. Heat often helps with myofascial pain. And if there's a big non-specific component to the low back pain, often muscles play a big role. And folks might actually find that, for example, they found that that heat helped them even before being recommended to use heat. They'll often find that after taking a hot shower, their back pain feels much better. Cold is often used for inflammation, sort of to calm down and soothe inflammation or swelling. So, for example, like arthritis in the knee. So that might help with calming things down. And so sometimes it may be worth employing alternating heat or cold as part of the management.
Okay, and here's kind of on these similar modalities. Someone asked about cupping. Do you have any thoughts on cupping for pain relief?
Yeah, I think cupping. I couldn't say I'm an expert on the philosophy or approach to cupping. It falls along the lines of the complementary medicines, often with the use of acupuncture and practiced by a similar practitioner. It provides some degree of massage to the areas of the muscles where the cupping is applied. There's thoughts that it helps with increasing circulation and the flow of qi, but that goes into that sort of Eastern, approach if it was sort of applied with that intention. So more directly, I think it applies a form of massage.
Great. And I really like this question. If a woman asks, "Hi, would you speak to preventing back disease, please?" So that was going to be my question for you. But if you had to say top three
Right.
things, if you could say three things to help prevent back pain for our audience out there, what are your top three,
yeah.
Peter, that you would counsel a patient on?
Yeah, this is it is a common question. I would say keep moving, and that often translates to in the work setting. Sit-stand desks are often employed, but it's not about standing. It's not about sitting. It's about changing the position regularly. Often people will get back pain with prolonged standing and not just with prolonged sitting. The other is, getting good sleep and nutrition. So that often sleep is when those discs kind of help to rehydrate. And, the more sort of the longer period of the time of the day that you might be offloading those discs from the body weight and gravity during sleep, the better those discs might recover and help prevent the onset of degeneration. And I think, the other one was, I think I mentioned it together, but I was thinking nutrition. So a lot of it is just trying to stay healthy and maintaining a healthy weight. I think that ultimately helps with healing and recovery. So exercise, sleep, and nutrition.
That's great. And then the secondary part of that question is specifically, what is dry needling? They have a question about that.
Dry needling is a description of the technique that's used to address the myofascial pain. In the field of that area of myofascial pain, dry needling is using a small fine needle and inserting it into the muscle itself, using the mechanical stimulus, the presence of the needle itself, to stimulate that muscle that might be tight and might have a taut muscular band. Often the presence of the needle itself ends up helping to release tightness. And if you think about it as a very fine, very specific massage using a needle tip in the muscle to help relax that muscle is dry needling. Often it's employed by medical practitioners like ourselves, but also with acupuncturists using their needles. And, those needles don't necessarily have to have just like a hollow center for injecting anything. These fusiform needles can be used for acupuncture or dry needling. Often in the medical providers in Western medicine will use the injection needles and then also inject some numbing medication along with it. It's been found in the literature that the injection itself, the presence of that volume of fluid, can also help relax the muscle. It doesn't have to be a medication. It could also be saline.
Thank you. And how does an investment in just a good firm mattress solve low back pain?
I think there's probably a balance between firmness and softness for the mattress. So I think the ideal mattress for each person is a very individualistic choice. You ultimately want a mattress that supports your spine without allowing it to sustain sort of prolonged abnormal curves during the over the course of sleep overnight. So a firm mattress can be good to some degree, but too firm can actually also cause pressure points and maybe joint aches elsewhere that has your pelvis sort of tilted too much overnight. And a too soft mattress just allows your spine to sink in. So the two extremes are probably not too good, and somewhere in the middle. And where that falls for each person is an individual type of determination.
I totally get that question. I'm like the princess and the pea with my hard mattress and then my multiple soft layers on top.
Yeah.
So I feel you, whoever asked that question.
Yeah.
This is a great question. This is very big picture here, but if you could create a big infrastructure program for the human body where a bunch of research money gets pumped into one area with a hope for breakthrough innovations that alleviate the most suffering, what would you pick to focus on, Peter Wu? It's a big question.
To help the human body is that the main area?
Help, where would you? To relieve the most suffering of the human body.
Yeah, it's a very very great question. It's a very hard question, but there's, yeah, I couldn't say that there's one, especially even in our field where we think about pain in so many different respects. But, pain is up there, I think, because it touches on so many different areas. And, I mentioned that the REACH program here is really endeavoring to understand that, to relieve one thing. It's within the orthopedic area, but it's ultimately leads to pain. And so pain can affect across all sorts of medical conditions, and not just orthopedics, but it could, affect folks after strokes. It can affect, folks, after, in socioeconomic dire straits. So pain, because it's so abstract, pain because it affects so many different areas. It's also partly why I went into the field of pain, because it's so diverse, and it allows us to engage and touch on different, a majority of the medical field. Our interactions with providers span collaborating with neurologists, anesthesiologists, orthopedists, all the physical therapists, complementary medicine practitioners. So I think there might be a reasonable sort of approach to addressing pain, because it's so broad and reaches so many people. But that's what just comes to mind. I couldn't say that is like my final answer.
No, that's a great question. It is hard. There's so many. It's actually interesting. There was an impact study several years ago where they looked at modern medicine, what had the most impact.
Yeah.
And in the last century, and it was the treatment of coronary artery disease was number one. Okay, where people, if you're older, you remember back in the 80s, someone had a heart attack and they would die. Now people get stented, they go home the same day. It's like amazing. And then the number two thing was actually total joint replacement. So us orthopedic doctors can be excited that we've contributed. That if you think about it, if people had arthritis and they had pain, they became immobile, they couldn't function, they couldn't walk, and they would die. And now we replace joints and people are up and moving and active. It's so important to stay active. So it's pretty amazing. It's that impactful. And let's see, do we have time for one more question? Let's see, there are established framework for, are there established frameworks for back school programs? Are there specific education topics, body mechanics, functional movements, psychology of pain that are indicated to be most effective? Are they just all features of a back school program?
Yeah, that's a really good question. I think as more and more interest grows in addressing pain and back pain, the more we find that there are diverse approaches to back pain, to managing back pain. And so there are things like, active release, McKenzie method. There are things like neuromuscular reprogramming, and even institutions or clinics, based off of functional restoration. I couldn't say that there was something that that I know of that's specifically the go-to. A lot of folks who end up having chronic pain, they end up finding what works best for them. And that could be the most direct way with physical therapy, or some of the most esoteric sort of very nuanced, niche type of practices that they swear by, that is the only thing that helps them. So I think there's many approaches out there, but I would say at the same time, there's not a lot of folks who know all the approaches, because those who know the approaches really intimately are the folks that have chronic pain, and they unfortunately are the folks that know a lot. So just like the question about what's the best mattress, I think there's not a really definitive answer as to what's the best approach.
Well, I would love to thank everyone for participating tonight. Peter, your talk was amazing. And again, I learned so much listening to you every time. Some people have asked about contact to schedule with Dr. Wu. It can be found on the UCSF Orthopedic website. And the number to schedule an appointment is 415-353-2808. You're always welcome to call if you are suffering from back pain. Dr. Wu is happy to see you. And
Definitely up there.
I know you like that. I'm pushing for you. And anyway, but thank you all.
Thank you, everyone.